Good afternoon, everybody. Thank you so much for joining us for Mended Little Hearts and Mended Hearts current status of newborn screening lunch and learn today. We are joined by two very special guests, Jill Glidewell and Lisa Home. And today we're going to be talking about the newborn screening practices in the States and what has been done. Pulse oximetry screenings are effective at identifying previously undetected critical congenital heart defects. And research has shown that mandated pulse oximetry screenings are associated with a 33% decline in CCHD-related infant mortality. Despite CCHD screenings being added to the recommended screening panel by the Department of Health and Human Services in 2011, it still remains one of the least uniform conditions across the nation in various states. And so today we're going to talk about what is the state of newborn screening, and then what can be done to help advocate for the increased standardization and national collection and reporting of congenital heart disease screening data. And I'm going to now turn it over to the experts. Today we're joined by, like I said, two notable nationally recognized experts in this area. The first is Jill Glidewell, health scientist at the Centers for Disease Control and Prevention. For over 10 years, she's been in the position at the CDC, working within the agency's National Center for Birth Defects and Developmental Disabilities. She's a nationally recognized public health researcher on congenital heart disease, population-based surveillance, and the impacts of newborn screening for critical congenital heart disease. We're also joined today by Lisa Home, who is both a nurse and a lawyer. And Lisa is the clinical program manager for the Critical Congenital Heart Disease Screening Program at Children's National Medical Center in Washington, D.C. She's also an assistant professor of pediatrics at the George Washington University School of Medicine, and she guides clinical teams on nationally regarding CCHD screening data, collection, implementation, education, and quality improvement. Thank you to you both for joining us today. And with that, I'm going to hand it over to your presentations.
Good afternoon, everyone. Again, my name is Jill Glidewell. I'm a health scientist with CDC's National Center on Birth Defects and Developmental Disabilities, and I'm excited to share a bit of our work on congenital heart defects with you this afternoon with a focus on critical congenital heart defect screening. Next slide. Congenital heart defects, or CHD, is the most common birth defect with an estimated birth prevalence of about 1 in 110 live births. To date, CHD is the leading cause of infant illness and death resulting from birth defects. And about 1 in 4 babies born with a heart defect has a critical congenital heart defect, or critical CHD, and we often shorten to CCHD. Next slide. Babies with CCHD need surgery or other procedures in the first year of life. And critical CHD screening is a tool that can identify babies with CCHD. Oh, can we go back one? Thanks. CCHD screening is a tool that can identify babies with CCHD during their birth hospitalization so they can receive medical care early to improve their chances of survival. And as of 2018, all states in the District of Columbia had implemented policies to screen for CCHD. Now we can go to the next slide. Thanks. CDC tracks and evaluates CCHD screening policies. And as Scott just mentioned, a CDC analysis showed that state mandates on CCHD might decrease early infant death by up to 33%. So we know that the uptake of CCHD screening is very important. And also through our work assessing state policies, we've also learned that not all states systematically collect CCHD screening data or share data between public health programs, which could identify program improvement opportunities, as well as monitor the impact of early identification of CCHD. Next slide. Completeness of data collection is important for surveillance, monitoring of outcomes, process improvement, and evaluation of state CCHD screening programs. And as you can see from this figure, there's quite a bit of variation in types of data collected by states, creating difficulty in monitoring outcomes and evaluating the effectiveness of screening programs. We've found that 13 states do not collect any CCHD screening data. 5 collect data only on cases that have been confirmed with CCHD. 5 collect aggregate data, which typically just means overall numbers of infants that have been screened versus not screened. And whereas 31 states collect individual level data, which is often seen as the optimum, still amongst those types of individual level data, there's quite a bit of variation. And next slide. We assessed states' data sharing between birth defect surveillance and newborn screening programs and found that only 19 states reported data sharing between these programs, which maximizes their surveillance capabilities. This is important because newborn screening and birth defect surveillance programs are the 2 public health programs that are the most invested in CCHD screening. And the routine role of birth defect surveillance programs is monitoring new cases of birth defects, including CCHD, regardless of method of detection. So birth defects surveillance programs do have the ability to assist in the evaluation of CCHD screening programs and also can assess mortality, outcomes, and healthcare utilization of individuals with CCHD. Next slide. Of those states that did report sharing between birth defect surveillance and newborn screening programs, they used the shared data to identify cases of CCHD that might have been missed by screening, to ensure cases match between birth defect surveillance and newborn screening programs, and also to perform post-diagnostic follow-up of infants that had been identified with CCHD screening. And so to summarize, although 50 states and DC have implemented policies for CCHD screening, opportunities for program improvement, particularly around data sharing and collection, do persist. And next slide. To better understand when and how CCHD is detected, CDC funded a new project in 2021 as a component of a larger population-based surveillance of birth defects project to collect data from 8 states on timing and method of CCHD detection, which includes prenatal detection, CCHD screening, or detection after discharge from the birth hospitalization. And the goal of this project is to understand timing and method of CCHD detection, any disparities in timing and method of detection that may exist, whether timing of detection is associated with newborn healthcare utilization. And these 8 states will conduct surveillance on CCHD cases, again, ascertain when and how the CCHD was discovered, and they will collect data on CCHD screening results, as well as timing of the confirmatory echocardiogram. And next slide. In addition to our work on CCHD screening, since 2012, CDC has conducted population-based surveillance of congenital heart defects, including CCHD, by linking birth defect surveillance, electronic health care, and claims data. And we've increased the number of CHD surveillance sites that we support from our pilot project in 2012, and are currently able to support 7 sites for our newest project, congenital heart defect surveillance across time and regions, or CHD STAR. And we've used the surveillance data to examine health outcomes and healthcare utilization among children, adolescents, and adults with CHD. And in CHD STAR, we also plan on examining timing and method of CCHD detection, as well as gathering screening results. Next slide. And thank you for your brief attention. And will hold questions till the end. And I'd like to turn over to my co-presenter, Lisa Home. Lisa has worked for many, many years in the field of CCHD screening, as Scott also gave a nice introduction to her. And she's always been an invaluable resource to states as they've implemented CCHD screening, and she will expand upon some needs and opportunities with CCHD screening. Lisa?
Thank you so much, Jill. You're so very kind, and we really appreciate you, Scott, for hosting this opportunity for Jill and I to meet with all of you guys. And as you've heard from Jill, we've accomplished a lot together in the past 10 or so years. And I know that CCHD would not be as CCHD screening would not be where it is today, with all 50 states having programs, without parent testimony and the dedication of so many advocates like you guys who are working to save and improve lives. So thank you guys for your interest in this topic and all the work that I know we've done collectively to date. Next slide, Scott. So certainly there's a lot to celebrate, but there's still a lot of work to be done as well, as Jill alluded to. We know that CCHD screening is making a difference in improving lives and identifying infants with critical congenital heart defects, but it does remain one of the least uniform conditions when it comes to both data collection, analysis, and integration with other important state health surveillance programs like birth defects registries. Next slide. So more good news is that we do have a recommended minimum data set, and this came from a manuscript that was published in Pediatrics in 2013, which laid out, based on some of the goals around newborn screening, to make sure that infants are all being screened and identified at their birth hospital with CCHD if they have that diagnosis. We do have recommended minimum data sets at both the hospital and state public health levels. However, many state programs lack the basic staffing and infrastructure to collect all of these data elements. As Jill shared, states' ability to collect data, as well as the specific data that they collect, vary greatly. And some of this is based on resources, and some of it is based on what they're allowed to collect based on policy. Next slide. Another tool that we have in place nationally, which is partially HRSA funded, is through the New Steps, or Association of Public Health Laboratories. We have a team called the Critical Congenital Heart Disease Data Response Team. And that's something that I've had the privilege of co-chairing along with my colleague, Amy Gaviglio, who got her start, well, maybe not her start, but worked for many years in newborn screening space in Minnesota in the Department of Health there. And the goals of this data response team are to identify gaps in CCHD data collection, analysis, and reporting, as well as to collaborate with stakeholders on quality improvement and education efforts, as well as, I'm not a technical person myself, as Scott and the team can attest to. I had trouble just connecting to this webinar, but connecting state programs with those who are really good at some of the technical aspects of interoperability, where the data might live in different places within the state, whether it's at the hospital electronic health record system, or whether it's out a bigger sort of public health surveillance data repository. And so this data response team includes representatives both from state newborn screening programs, federal partners, and other advocacy groups. Next slide. So New Steps does have a national data repository, and these are some of the cases that we know have been identified through newborn screening using pulse oximetry between 2012 and 2021. So 12 states reported or contributed data to this, and it includes 612 infants with a variety of critical congenital heart defects. So this is really great. However, only 12 states are reporting because this is voluntary, and some of the states have barriers to reporting, and some of the states, as Jill mentioned, don't collect CCHD screening data. Another limitation of this data is that it relies on self-reporting. This is not a systematic collection of all the infants in those 12 states who are identified. It relies on folks in those state newborn screening programs to put the data in manually. So based on this self-reporting, we know that CCHD is making a difference. However, it only represents a fraction of the outcomes data we need to fully understand the impact of screening on CCHD screening outcomes. Thanks, Scott. Next slide. Okay. So this data is from the same source, from the New Steps data repository for CCHD screening. And when we looked at the data, what was really interesting is that the find rate varies greatly by state. However, without a centralized and systematic data collection system, it's really hard to determine why this variation is occurring. So the red bar captures the state's annual birth rate So you can kind of get a sense of how heavily populated that state is. And the green line represents the find rate. So the variation is anything from 12 cases per 100,000 births to 1 case per 100,000 births. So we really want and need national screening data, patient level screening data, to be able to understand why this variation is happening and how we can really improve this data for everyone. Thanks, Scott. So this slide is just meant to be another example of some of the areas that really require more attention. So some of the good news that Jill shared is that many states, the majority of states, do collect some patient data, and that many states do collect individual patient level data, which is what we need to be able to complete analyses. However, I wanted to use this example of California to show that, you know, we really do need more investment in data infrastructure. Like many states, California is a state where CCHD screening is an unfunded mandate, so no resources or dedicated staff were added to the budget. That state was told that they just needed to add it and start screening. So one report from the California Department of Health Services in 2016 described receiving CCHD screening reports for only about 60% of state births, which means that we don't know if the other 40% are even being screened at all. Another follow-up report from a different source, this is from another team looking at it, but in 2021, found that in California alone, approximately 359 infants with CCHD are likely missed or unaccounted for each year due to this non-reporting. So a third of hospitals in 2021 were still not reporting. And without this data, the team who published this research had serious concerns remaining as to whether all infants were being screened and benefiting from this life-saving newborn screen. Thanks, Scott. So investing in technical infrastructure and data systems will improve outcomes. And I just wanted to give two examples of how that could happen. And one is to improve data delays. A lot of these delays are taking place because of a lack of staffing, funding, and informatics infrastructure. As well as the second way is that it can help with upgraded data systems. So interpreting the screening algorithm can be a little bit confusing, especially as we know newborn screening is not happening in isolation. There's a lot of other things happening in a newborn nursery when the infant's being screened. And the algorithm can be a little bit complex to interpret. One study conducted by Matt Oster and his team found that screeners correctly identify or interpret a screening fail without electronic decision support only about 65% of the time. So with the ability to integrate and embed things like algorithm decision support, that number can improve and we can identify more infants and make sure that the protocol is being interpreted correctly. So I just wanted to give you those two examples of how those investments would make a difference in identifying and improving outcomes. There's other teams that are also looking at simply trying to simplify the algorithm, and that's a group with the American Academy of Pediatrics that's currently looking at whether the algorithm can be simplified as well. Thanks, Scott. Next slide. So in summary, there definitely have been successes in screening, but challenges remain. We're very happy to say that CCHD screening is offered in all 50 states in the District of Columbia. However, the outcomes of screening are still very difficult to quantify, and data collection and infrastructure development is essential. Thank you, everyone, for your time. I think we still have a little bit of time for Q&A, and Jill and I would love to hear from you and hear what questions you might have or comments you'd like to share. Thanks, Scott.
Great. Thanks so much, Jill. Thanks so much, Lisa. Very informative. I know we've got a couple of questions we want to get to that were made in the comments, but you know, I'm curious if there are any states that we can look to that are doing CCHD screening, reporting, and and really the follow-up, kind of who are the star states that we can look to potentially, model other state activities off of?
I don't know, Jill, do you want me to start, or would you like to take this?
Lisa, how about you start?
I think we probably have some of similar states in mind, but I don't know if I want to.
Yeah, given your work with the data response team and those states that volunteer and participate on that group, how about you start with that? And I think that my answer would probably be pretty similar, but go ahead.
So Scott, I know this wasn't the question, but based on my work with the data response team, I know that in some states, there's only one staff person to cover all of the state's births for all of the newborn screening conditions. And I think there's over 30 at this point. So a lot of, the reasons why a state might not be a star when it comes to data collection analysis and improving outcomes may be simply that state is under-resourced. So with that being said, I will say that some of the better resource states that have presented on some of our webinars that are further along in terms of implementing screening and identifying and understanding their outcomes, I think Minnesota is definitely one of those states. I think Florida has presented several times and has done a lot of work on some of the technical infrastructure for reporting. And then I think certainly the states that Jill mentioned that were selected to be able to participate with the CDC projects, those 8 or 9 states also can be considered sort of front runners in terms of making sure that this work is progressing nationally. So I don't know, Jill, I'm happy to be corrected, or if you want to amend to that list.
And just to echo, and I think on some of our more recent publications, we've chosen really not to highlight those that are really the best states, and some that could do a better job, simply for the reason, Lisa, that you mentioned, which is not always, it's a staffing, a resource barriers issue. So yeah, I think that I would just echo the states that you repeated, and some of the early trailblazing states like New Jersey also doing a great job.
Absolutely.
Great. Yeah, I know it's hard to answer that kind of question, and certainly we want to highlight those states that are doing well, but also look to them as trailblazers and ones that we can model after into other states through our advocacy efforts. So that's great to hear, and I know we've got some folks who are joining us from Delaware and New Mexico and are involved in newborn screening and advocacy there. So that's great. One of the early questions we got in the chat was about the accuracy between different race and ethnicities of pulse oximetry. And I know we're talking today about that screening component, but I'm just curious what the early kind of research has shown. I know this came up a lot during the COVID pandemic as well, of using pulse oximetry as a marker for blood oxygenation level. And so just curious what your thoughts are on its use and the differences in accuracy among race and ethnicity.
I think I'll start, and then I'll punt it over to Lisa from a clinical perspective. That is something that we're looking at through our new project, is if any racial ethnic disparities exist in timing and method of CCHD detection. But for the, Lisa, I don't know if you and your group have looked at, the accuracy of pulse oximetry by race, if there's anything you could share there.
So I can't think of any sort of big pieces of landmark research in this area. There have been some studies that were recently published with regards to prenatal detection, so fetal ultrasound and race. There was a study that came out from my team, actually, Dr. Anita Krishnan, who was looking at the rates of fetal diagnosis for CCHD, and found that some of that mirrors, at least for 2 specific lesions that she looked at. I think they were hypoplast and tetralogy, but I could be wrong. I think I haven't read it recently, but certainly there was a tie to sociodemographic status, and so specifically for prenatal screening. And I think that that is something that wouldn't be a surprise in terms of mothers who have access to prenatal care and who are able to get that 20-week ultrasound would have better find rates in terms of prenatal diagnosis. But I think it's definitely an area that researchers are interested in. And in terms of specific pulse ox studies, I can't think, I've seen some smaller studies that maybe have looked at pulse oximetry biases based on skin color, but I can't think of like a big study that's really come out on this issue, Scott.
Great. I think that's really helpful, just given some context to that this is an area of interest for researchers in terms of also studying the impact of, maybe we'll be able to see some disparities there and figure out ways, as you had mentioned, the algorithm program support can maybe help address some of those. I would like to take a question from Lori, who talked about, is there a connection to organizations like the Children's Hospital to help advocate? So in the past, what kind of organizations have been involved in these efforts, and how can more folks get involved, like Mended Hearts and Mended Little Hearts, to continue to push states and for federal funding, and increase infrastructure for newborn screening and detection? I guess to summarize that question, just what are the organizations that have really led these efforts, that have come together for newborn screening?
So some of the big players in terms of implementation and asking for those CCHD screening mandates have been large medical or trade associations. For example, I think the big ones were certainly American Heart Association, the American College of Cardiology, the American Academy of Pediatrics, March of Dimes, as well as sort of the New Steps group. And I know CDC was really helpful in terms of providing a lot of the background studies that sort of looked at this issue and said where the need was. So certainly there were federal partners, not at the advocacy level, but at sort of providing that research basis to be able to say that there is a need for something like CCHD screening. And so I'm looking at Lori's specific question about Children's Hospital Association. So I know Children's Hospital Association used to do a lot of sort of scorecard metrics and analysis for congenital heart disease based on things like surgical mortality, and working with perhaps the Society of Thoracic Surgery Congenital Heart Database. But I think a lot of that data is driven by diagnoses codes and looks at things like surgeries and cardiac catheterizations, and is somewhat procedural, or as well as things like length of stay. I don't know that Children's Hospital Association, to my knowledge, has looked at things like method of detection for CCHD. But I think it would be great if there was a national platform. I know that there are limitations with the New Steps repository. It really represents just a fraction of the data that's out there. Jill, I'd love to hear if you have additional thoughts as well.
No, I think you covered it. And I think, again, with the support of our patient parent groups, such as Mended Hearts and Mended Little Hearts, really a lot of progress was made, and we appreciate the support for many years for this effort.
Absolutely. We could not have done it without the parents testifying and telling their stories at the state level in pretty much all of the states. There were parent advocates saying, we need this.
Great. Well, I know that this is a priority for Mended Little Hearts this year, and probably for many years to come, to really try to help improve this system. I think there was a lot of advocacy and garnered a lot of attention about a decade ago as states were going through and mandating this. But I think there's, as we've shown today through your presentation, there's still a lot of work still yet to be done on the advocacy level. So we look forward to working with you and with the advocates who are joining us today on really creating, a culture in the States of really taking a look at this and shining a light on how we can do better for critical congenital heart disease patients, as well as, infants born with all sorts of birth defects and disabilities. And so, one way that we have identified that we can help support these efforts is through the Newborn Screening Reauthorization Act. This is a bill that has to be reauthorized every 5 years, and the last authorization expired in 2019. But really, there is some provisions that talk about establishing standardized data collection and reporting to electronic health records, and really promoting those data linkages between the programs, screening programs, and the birth defect surveillance programs. So, it has been passed in the House. We are coming to the end of Congress about the election, about January 1st. So we really are looking to the Senate to really push push on this and really get it passed over the finish line so it can go to President Biden's desk. So look for more information from Mended Little Hearts on that. And one of the best ways to get involved on this effort with the Newborn Screening Act, or with some of our emerging programs, perhaps in each state to advocate, is really to sign up to be an Action Network member. And so we're going to put in the comments here how to join the Action Network and be a part of the advocacy program and really work on this. And if you have a particular interest, we encourage you to email Mended Hearts or leave a comment on the page or in YouTube, and we will get back with you and really have you join these efforts with us. So with that, again, I want to thank Jill and Lisa. Your expertise and your passion is clear, and really appreciate you really being able to help educate and inform our community on this topic, and the importance of that our work is not done, and that we still have more work to do to really help ensure more CCHD patients are diagnosed timely and receive the appropriate care. I shared in one of the comments, I was diagnosed at 6 weeks old, and my mom always says it was nice that I had that 6 weeks to take me home and have a normal newborn. But as somebody who follows public health policy, I see how life-threatening that was, and I think that we really should be doing all that we can that there's less children who are diagnosed weeks into life and are rather diagnosed either prenatally or within a few days. So thank you all for your work.
Thank you again for the opportunity.
Thanks for all you do. Thank you.
Great. And thank you everybody who's joining us at home. We look forward to having you join us on the next Lunch and Learn. Take care.